All right, guys, so I'd like to carry on with high-risk newborn. So PKU is an autosomal recessive disorder that, uncorrected, can lead to mental and physical developmental delays in the child. You can see the number of babies that are affected, and you can read sort of about the pathology of it here. You know I'm a visual person, so next slide I'm going to show you the visual of this. So what you have with PKU, if you look at this image on the right, is that this in most of the foods we eat, we're exposed to this protein. And people with this disorder have a defective enzyme, so they can't process this protein. So they get this high level of it building up in their blood, and as a result, it can lead to mental and cognitive dysfunction. So you can see a picture of a baby having that newborn screening test, which Professor Sullivan talked about, where we do a heel stick on the lateral aspect of a newborn's foot, and we fill these 5 circles with that newborn's blood, and this gets sent off to the state lab. It is critical, guys, that as nurses, we ensure the screening test is done, documented that it was done, collected, and sent to the state lab. Aside from measuring and checking for PKU, there are a multitude of other disorders that are tested for on this newborn screen. One of the others is hypothyroidism. Babies can be born without a thyroid gland, and if this newborn screening will pick that up. If a baby goes without thyroid hormone, it will become mentally retarded as well. So this screening test is imperative that as nurses we are ensuring every baby had before it leaves the hospital. So I want to talk to you guys about sepsis. The signs of sepsis in a newborn can be fairly subtle. You'll see respiratory distress is one of their symptoms. And right above that, these babies with sepsis are typically going to be hypothermic. Their temperatures are going to be low. So look at these. Be familiar with the signs of sepsis. What can cause sepsis in a newborn? Well, we talked about 2 things. One is obviously group B strep if the woman is positive and is not treated with antibiotics in labor. Her baby is at risk to pick up that GBS disease on its way out. So those babies who don't get the adequate dosing through mom getting that penicillin in labor, they're going to be monitored for signs and symptoms of sepsis. The other thing we talked about is clearly the baby who's exposed to herpes can get severely septic from that. And I want to just put here that not every mom who is GBS positive and doesn't receive antibiotics because she has her baby too fast, didn't make it to the hospital, not every baby that's exposed will become septic, but clearly those babies are on our list of being at high alert for sepsis. So in congenital abnormalities, for those of you who've taken PD, this is where I think you may be familiar with some of these. And for those of you who haven't taken PD, let's introduce you to them. So when a child is born with any malformation, typically the parents may have an idea that it's happening because the baby has had an ultrasound and that abnormality has been discussed already. In a woman who maybe didn't have an ultrasound or went to care late and didn't have that benefit of an ultrasound, an abnormality at birth could be really a shock for her. So I can give you an example. I took care of a patient in Stanford, her and her husband, and they hadn't had any ultrasounds, and their baby was born with a cleft lip. When that baby was born, the first thing parents do is count. Are there 10 toes? Are there 10 fingers? They look at the baby's face. And in this case, when the baby wasn't what they had in mind, there's a grief process that starts. So as nurses, when there is an anomaly, we want to model good behavior. We want to be talking with this baby, interacting with it just in the way we would any other child to help the parents to start with this acceptance process. So this is showing examples of that cleft lip and cleft palate, and then the repair on the right side. Cleft lip obviously is looking more concerning for parents. That's what they're visually seeing. But clearly cleft palate, guys, is the bigger issue, harder repair and has more complications, even though it's internal and parents don't see it overtly. Obviously the cleft palate is the harder one. Can these happen together? Absolutely. You can have both the cleft lip and the cleft palate. This is the baby with both. So cleft lip on both sides, and there may be some palate issue going on as well. And then the repair on the right again. So when do these repairs happen? It's important to be able to tell parents if this is going on, because parents think, oh, we're just going to, fix this right away. Well, a newborn baby isn't up for general anesthesia and surgery. So that lip doesn't get repaired until at least 3 months of age. And then the other thing is, if there is a cleft palate, that waits all the way till a year. It has to happen right at that year of age, though, because if the baby makes it 6 months later to 18 months, it starts developing speech issues as a relation to not having had the repair. So the cutoff is we really want the repair by a year if it's a palate. So these are pictures of something called a Haberman feeder, and you can see that this bottle will allow the nipple to get back further in a baby's mouth if it has cleft lip or cleft palate to be able to try to feed. So mom can pump breast milk and it can go in here, or if she's formula feeding, that can be put in here as well. But breast is going to be best again with these babies. For GI issues in terms of malformations, there can be esophageal atresia or tracheal esophageal fistulas, and this would be very concerning and potentially require surgery in these kids. There can be diaphragmatic hernias, which is displayed here. And then the other two things that we've spoken about with GI are omphaseals and gastroschisis. So we know that during in utero development, our abdominal organs, every one of us listening to this, all of our organs developed externally. They developed in part of the cord. So I'm going to draw here. You can see the umbilical cord here coming up, and this omphaseal is an offshoot of that. That's how we all develop. However, in this baby, the abdominal organs did not go back in as they normally should have. So that's what's going on in these cases. Nursing care if a baby is born with either of these is to immediately take wet gauze, right, wet with a sterile solution, and wrap these organs. You would never put something dry on it because clearly that will stick. So wet gauze that's wet with a sterile solution, wrapping these organs to keep them moist. This is an example of how that repair happens. These babies' bellies don't get opened up. They actually have the organs hanging sterilely, and by gravity, the organs go back into the baby's body. We can't just open up the baby and automatically plop all of these organs back in their body. It needs to happen by gravity with time. And so again, huge education point for parents as they're coming in to visit their baby, and this is what it looks like. Really great areas for communication and working with the whole family in the NICU setting. So the next sort of anomalies to speak of are CNS, and so central nervous system, and neural tube defects come up. Remind yourself what prevents neural tube defects, and sort of thinking about that with this conversation. So it can be occult in this first image, and what you see with occult is sometimes just a tuft of hair in that area where the spina bifida is occurring, or it could be that the meninges are protruding or part of the spinal cord is protruding. So you could see it's in progression of least severe to most severe. If it is one of the second two images, the more severe ones, that's probably going to have been picked up on ultrasound. So this is showing what it would look like at birth if a baby had spina bifida. Another one here with the myomeningocele. Again, you can see the gauze in this situation as well. Wet gauze would be used, again, sterile. And then congenital cardiac defects, again, for those of you who didn't take PD, I don't mean to be saying you should know these, but I want to sort of think about cardiac defects in infants. If it's not diagnosed before the baby is born, usually if there's a major cardiac issue that's happening and the baby's at a smaller community hospital, these babies in Connecticut will get sent to Yale for care. And that comes with a whole host of things to think about for mom, right? Is mom going to be transferred, or is mom going to await discharge? So thinking about what that means for the mother-baby dyad. More babies, die from their cardiac defects than any of other abnormalities that we've spoken about today. And with babies with these cardiac defects, a hallmark sign of them is that they're cyanotic more so when they're active, okay? That's a difference from a lot of the other cyanosis pictures we've talked about. So these babies get, active and get crying. A normal, healthy kid perfuses more when it's doing that. These babies don't, because they're working harder and clearly have a cardiac defect. So I'm not going to read all of these and sort of dissect them all. It is something that is usually tested in the pediatric setting, so it is not on our exams, but it is something, this is another way to review for PD, to think about cardiac defects and exactly is what's happening. So you'll see up in A, it's a ventricular septal defect. So there's a septum. You can see exactly where that's occurring, okay, right here. And then you have the patent ductus arteriosus, okay? What's occurring here? We sort of, talked about some cardiac issues today. So think about these in context of what you would look at in your baby. Coarctation of the aorta is in C. In D, we have tetralogy of Fallot. And then in E, we have transposition of the great arteries. So again, not on our exams. More. So the last thing to think about in terms of anomalies that a baby can be born with is I talked about briefly amniotic bands. This is an area of tissue that forms abnormally, a band that forms abnormally in the amniotic cavity, so where the baby is living. These bands can basically attach to a limb of the baby. So in this instance, it's showing the bands attached to the finger. And you can see that these fingers are losing perfusion because of these bands, these fibrous bands that form. So if these constriction bands form around any portion of the developing fetus, that portion will not develop. So in this case, you can see in the lower image, the baby's hand and how it was affected from this. So the fingers did not develop. In this case, it's just the fingers. However, it can happen to a whole hand or a whole foot. So again, typically depicted on ultrasound, diagnosed beforehand, but again, with somebody not having care, we could be diagnosing for this at birth. All right, and please let me know if there's any questions.